Good afternoon, everyone. My name is Ahmad Elsaid. I'm one of the final year cardiology interventional trainee in Within Show Hospital, Manchester in the United Kingdom. Thank you for the committee for offering me this opportunity to present my case. Thank you for the panel for the audience to attend this case. I have no conflict of interest to disclose. My case is about an 83-year-old gentleman who presented to the local district hospital with non-stimulation myocardial infarction. His past medical history included colonic polyps, diverticulosis, AAA repair, good exercise tolerance functionally. His investigation showed, his echo showed a preserved LV function with no significant valve disease, no regional motion abnormalities. His blood tests were reassuring, lipid profile was not significantly raised, and he didn't have diabetes. His initial setup pictures were done at the local DGH, and it shows a right dominant circulation with diffuse plaque disease in non-obstructive right coronary artery. In the left circulation, we can appreciate a bifurcation left main LAD LCX disease with a Medina classification of 111 heavily calcified disease, and the LCX furthermore is classified down the vessel and with severe disease down the vessel. We couldn't appreciate an LAD antegrade flow in those pictures provided to us, but we knew from the echo that he had preserved LV, so some LAD flow must have been preserved. He was discussed in the heart team meeting. He was offered both options. He opted for BCI, giving his age group, and that was his personal choice after seeing a surgeon and a heart doctor, and he was accepted for high-risk complex BCI. With this, we have discussed with him the risk of the procedure, about 5 to 10%, and we have agreed for biradial approach, and also we have agreed for upfront two-stent strategy, giving the calcification and the extent of disease. This is the initial setup of the procedure. We have passed the cyan blue in the LAD, and we have got the left side pictures. In the RCA, and then we have got left side pictures. This is the initial pressure trace. And then following that, we have the Fielder XT traversed the LCX, then it was exchanged for a cyan blue with a supportive microcatheter, and then the Fielder XT failed to move beyond that point in the LAD, and then it was exchanged for a Gaia second, which managed to traverse to distal LAD. At this point, the patient started developing chest pain. He started having low blood pressure, and he was restless. We anticipated that we have very little time to act in the coming step and to restore flow. We were ready to pull out one of the wires because having two wires in his microchannel left main caused this hemodynamic compromise. But luckily, we were able to pass a balloon down on one of the wire and another balloon on the other wire, and then we have managed to do sequential balloon inflation and then kissing balloon inflation, which managed to restore flow. I'll have to speak up for the team here because that was very efficient 3 minutes that we managed to exchange the wire, pass the balloons, prepare two balloons, pass them, inflate them, sequential, and then kissing balloon inflation, which managed to restore the flow in time. This was his flow, was his BB trace, and also the ST segment resolved after restoring flow. Now we had time to think, we had time to breathe. It's time for the muscle to breathe as well. Following that, it was time for IVUS to appreciate what's the vessel size, what's the next step for us, how much calcium we need to tackle with. So we passed the IVUS to mid-LAD, and from that point, the vessel reference diameter was 2.5. Proximal to that was a 3.0, and then there was eccentric calcium at both sides here, and then another the islands of eccentric calcium here. It was difficult to find the segment in the left main with no calcification to find the vessel diameter, but we managed to see that the vessel diameter of the left main is about 4.0. The left main was heavily calcified. Moving to the LCX, we have seen a distal vessel diameter of 3.5, mid vessel diameter, and proximal to that is a 4.0, and then a 4.0 at the left main as well. To modify the block, we took 3 NC balloons, 3.515, and we took sequential balloon inflation and then kissing balloon inflation at both wires. During that procedure, the chest pain has gone, but the patient remained restless. He was not able to rest on the table. We kept communicating to him the steps, what we are doing, what's left, and that made us to revise the strategy to accept less than ideal calcium modification. So we took a cutting balloon to the LCX, which was difficult to pass given the osteal calcification of the LCX, but managed to modify the plaque further. At this point, we appreciated it is time to stop calcium modification and accept less than ideal result and proceed for stenting. So we started by paying attention to the distal vessel. So we have stented the distal vessel with a 3033 DES. And then in the LAD, we also passed a similar stent 3033 DES to the distal LAD. And then we focused attention into the bifurcation. We opted here to go for a mini crush strategy, and here we have taken a 3528 DES proximally in the LCX, and with a sentinel balloon 3520 in the NCE compared to the vessel diameter. We tried to rewire the side branch, which was difficult at this point. What we managed to do next is to do a bot crush, which helped to influence the proximal leading edge of the stent, of the LCX ostium, which managed to recross after that. And then we have placed the main vessel stent 3533 DES. Then we have dewired the LCX before we do the next crush, the next bot, Following that, kissing ballooning inflation, followed by a final bot. The patient didn't tolerate further, and we opted not to perform the final IVUS because he wouldn't stay more for it. Those were our final result. It was a geographically satisfactory result in his situation, given all the limitations that we have in the case. And our learning point from this case was anticipating critical steps and identifying deterioration early helps turn failure into success. Key point in success is communication between team members and keeping them following the journey of the patient. Procedure efficiency is a must, and adapting techniques to patient needs and current evolving situation were essential in this case. An initial plan was very important, but it can change at any point. Bot crush helped in crossing the side branch, and the main vessel size is usually larger than the main branch size. This leaves the leading angle of the side branch stent under crushed. Thank you.
And your lesions in this patient were as complex as the patient was considering his comorbid conditions. So I think these kind of chip cases, they usually require an upfront mechanical circulatory support. So could you thought of using that impeller anytime during the procedure, because you said you had to do the kissing balloon inflation twice to relieve that hemodynamic compromise in chest. So did you consider using this impeller in this case, or it was?
Impellers usually would have helped in such situations. Our access to impellers is very limited, so it wouldn't be justified in someone who has normal LV based on our criteria and our local experience in the center. But if it was there, it would definitely bought us time to do those steps at relief rather than very hastily.
And just on the audience, how many of us are using, like on the audience, are the proponents of DK touch assistant that from that? Just use. But after the results of these, because you may be proponent or opponent of various techniques, but after the results of this DK touch 5, I think that's the default. So, any comments from the audience?
She didn't do normally the lines was fine. I've had look get to the microphone.
So I think it we are about the tech.
Yeah. Thank you for the rest.
Thank you.